Hello again. This lecture covers infectious respiratory diseases in the transport environment, and I want to approach this practically and um, kind of agnostically. Um, whether you're transporting a patient with community-acquired pneumonia, viral influenza, RSV bronchiolitis in an infant, or COVID-19 associated ARDS, or any other infectious respiratory disease. The clinical principles are more similar than they are different. Um, the job then is to recognize the severity of the respiratory failure in front of you, apply the right oxygenation and ventilation strategy, protect yourself and your crew first and foremost, and then get the patient to definitive care without making things worse. We'll cover the major infectious syndromes, the oxygenation and ventilation strategies that apply to each, infection control in the transport environment, and the high risk populations that need your sharpest attention. Here's what I want you to be able to do after this lecture. First, recognize and describe the common infectious respiratory syndromes that you'll encounter in transport. Things like pneumonia, bronchiolitis, influenza, COVID-19, and then understand what distinguishes their clinical presentations and their complications. Second, identify when an infectious respiratory patient is deteriorating towards hypoxemic respiratory failure or sepsis, and then know how to respond. Third, apply oxygen and ventilatory strategies to these patients, drawing on the lung protective principles from our earlier lectures. And then fourth, know your PPE obligations. What constitutes an aerosol generating procedure? There's always some controversy around that. What precautions are appropriate, and how to protect yourself and your team in a confined transport environment. And then fifth and last, recognize the high risk populations, infants, the elderly, the immunocompromised, pregnant patients, where your threshold for escalation needs to be lower. If you can't tell, I like these tables. I think they're nice visuals, and they kind of harness a lot of information and in one spot so that you can have a quick reference and resource. This particular table maps the major infectious respiratory syndromes to their typical pathogens, their clinical patterns, and their transport implications. Um, Use it as a reference map, not to diagnose the pathogen in the field, because you can't, culture a sputum in a helicopter, but to frame your clinical expectations. Bacterial pneumonia, to start top left, that tends to present with consolidation, productive cough, and a more classic septic picture. Um, Viral pneumonia, on the other hand, like influenza or COVID-19, often presents with the more diffuse bilateral pattern and a greater tendency toward rapid hypoxemia and an ARDS pattern type of failure. Um, RSV bronchiolitis in infants, especially, produces um, a pretty standard clinical picture. We've talked about that in previous lectures. You'll find wheezing, hyperinflation, secretions, and that's different from either bacterial or viral adult pneumonia. And the overlap cases, secondary bacterial pneumonia superimposed on viral illness, those often represent the highest acuity presentations that you'll transport. So take a look at this and just to be able to kind of differentially diagnose each one based on these three um, key clinical findings. So let's start off with pneumonia. Pneumonia is one of the most common reasons for interfacility transports, and the severity assessment at the departure is probably the most important task. When you approach a patient with pneumonia, try to use a simple clinical framework. What's the work of breathing? What's the SpO2 on their current oxygen? What's their hemodynamic status? Is there any kind of sepsis associated, possibly hypotension, things like that? What's their mental status? And what is trending? Is the patient getting better or worse? A patient with lobar consolidation with a SAT of 93% on 2 liters and a normal mental status is a very manageable transport patient with close monitoring. A patient with bilateral infiltrates, a SAT of 88% on a 15-liter non-rebreather, and they're confused, well, they're already likely in moderate to severe ARDS, and you'll need to make very deliberate decisions about both oxygen delivery and airway, and consider early intubation. For oxygenation for pneumonia patients, given that they don't have a underlying COPD history, you should target a SpO2 at or above 94% in most cases. If the patient's already intubated, you're going to be looking at lung protective settings from the moment that they're on the ventilator. So those include low tidal volume, appropriate PEEP, and minimal FiO2 to reach the target saturations. Always verify that antibiotics are running before departure, if at all possible, especially if it's a confirmed bacterial infection. The time to the first antibiotic matters, especially in septic pneumonia. RSV, respiratory syncytial virus, and bronchiolitis, kind of interchangeable. Bronchiolitis is a form of RSV. Those are two of the more common serious respiratory issues that patients are transported for, especially with the pediatric population, especially during the winter months. The typical patient is typically an infant or a toddler, often under 2 years old, uh, who have had several days of runny nose and a cough that have progressed to increased work of breathing, poor feeding, and hypoxia. The pathophysiology is small airway inflammation, so bronchiole inflammation, and edema or swelling from the viral injury, from the virus itself. It's not bronchospasm in the classic sense, which is why bronchodilators have very limited evidence in this population, and you should not rely on them. Airways are also plugged with mucus and debris, so secretion management should be one of the more important interventions. Gentle but thorough suctioning of both the nasal and the oral pharyngeal airway. They often produce dramatic, if temporary, improvement in both airflow and oxygenation. Um, Oxygen delivery is titrated to keep SpO2 at or above 90 to 92%, or whatever your facility recommends or requires. Um, in terms of escalation therapy, high flow nasal cannula is almost always preferred. especially with the in the infant or the toddler with increasing respiratory distress. High flow nasal cannula provides flow and some modest pressure support and some unmeasurable small amounts of PEEP even, um, while avoiding intubation. Intubation in the bronchiolytic infant is always used as a last resort, because positive pressure in these small hyperinflated airways carries a really significant risk of both barotrauma and worsening air trapping. The biggest thing to focus on when transporting patients with bronchiolitis, RSV, is to make them as comfortable as possible. You're not going to fix the issue. Minimize agitation, minimize heat loss, ensure that if they're on any kind of adjunct or supplemental therapy like high flow nasal cannula or BiPAP, or even if they're intubated, um, make sure that the circuits are heated if at all possible, and that you're doing everything you can to make the patient comfortable. Be ready for rapid deterioration or even apnea in young infants, because they can change on a dime, and it's pretty scary to see. One of the more difficult um, um, things to differentiate with diagnosis, especially if you don't have a confirmed swab, a flu swab or a COVID swab, is to identify the difference between a patient who has influenza and something like a COVID-19 pneumonia. So this table kind of contrasts influenza and COVID-19 pneumonia to help you understand the patterns that each produces in critical illness. So both influenza and COVID-19 can cause a very serious, severe ARDS pattern respiratory failure, so a restrictive type of respiratory failure. But COVID-19 in its severe form, and I know we're not seeing as much of that obviously as we did when it was rampant, but there are still um, cases in the hospitals. It's still going around, but in its severe form, COVID-19 has some unique characteristics that are worth noting. And sure, it mutates and it evolves, and no two people's symptoms are the same. However, we do know enough now to be able to recognize if that is the issue, as opposed to influenza, especially as we're awaiting the results of tests. But early COVID-19 ARDS often presented with what was called silent hypoxemia. That's patients with very low SpO2 who appeared much less stressed than their numbers would suggest, um, right before they deteriorated rapidly. This is different from the typical ARDS presentation, where visible distress and work of breathing increase with worsening hypoxemia more slowly over time. Um, Both influenza and COVID-19 also carry a high risk of secondary bacterial superinfection, um, pulmonary embolism, and also cardiovascular complications. For transport, what matters most is the current state of oxygenation and ventilation. The pathogen itself is relevant context, but your management of the patient is driven more by the physiology that's in front of you, not the microbiological diagnosis. Table brings together the oxygenation and ventilation strategies that we've discussed throughout the course, and applies them to the infectious respiratory failure context. The key principle as you look this over, um, that ties all of these together is, no surprise, lung protective ventilation. Low tidal volume, so 4 to 6 mLs per kilogram of predicted body weight, similar to restrictive diseases like ARDS. Plateau pressures below 30, sufficient PEEP to maintain recruitment, and the lowest FiO2 needed to maintain the target SpO2. For the non-intubated patient with moderate hypoxemia, the escalation ladder goes from low flow to high flow nasal cannula and then on to non-invasive positive pressure ventilation via BiPAP, with intubation as the next and last step when those measures are insufficient or when the patient can no longer protect their airway. Either way, always communicate clearly with the receiving team about where the patient is on that ladder at departure and what trajectory you're seeing during transport. Most of this has been kind of reviewed so far, and this may be as well, but it's still important to cover. When we talk about infection prevention and personal protective equipment or PPE, especially in the transport environment, the biggest thing to consider, and this, is to protect yourself. Um, you come first. You and your partner come first. Patient comes second. I know that's kind of antithetical to the human nature of those of us who are in healthcare, but the patient is no good if you're not there and healthy to help them. Um, Infection prevention in the transport environment is not optional, and it's not someone else's job, it's yours. The transport cabin, whether in an ambulance or a helicopter or an airplane, the cabin is small. It's a small enclosed space with limited air exchange, and you're working very close to a patient who may be shedding infectious respiratory organisms. You don't want any part of that. Standard and transmission-based precautions are the baseline. For most bacterial pneumonias, you use droplet precautions, so a surgical mask, eye protection, gloves, and a gown. For influenza, COVID-19, tuberculosis, and any patient requiring an aerosol generating procedure, um, don't hesitate to upgrade to airborne precautions. Grab that N95 mask and use it. I mean, you can never be too careful. It's fairly common for healthcare workers to kind of go rogue and want to be the hero and think, oh, I'm there to help the patient. I don't matter, or I'm not going to catch whatever they have. Don't play that game. Suit up. It's far better to be more protected than underprotected in any situation where you're dealing with any kind of viral or bacterial infection. Um, the aerosol generating procedures, those those are a little more um, ambiguous. Like I remember when COVID was rampant, when we were going through it. I was manager at Borges for their respiratory department, Beacon now, and we were figuring out how to do things, how to manage the patients, how to involve or include, the equipment that we had, how to, and it changed constantly. One of the things that was kind of controversial was the idea of an aerosol generating procedure. And it was kind of across the board, wasn't just Kalamazoo, so much so that the CDC actually developed a list, comprehensive-ish list of aerosol generating procedures, um, and published it on their website, and that's what we used as reference. Um, so most of the things um, are kind of obvious, but some not so much. So aerosol generating procedures include intubation, extubation, open suctioning, bronchoscopy, nebulizer treatments, high flow nasal cannula, non invasive ventilation, and more. During flight, um, to maximize the aircraft's ventilation system, you should position viral filters on the vent exhalation port and avoid unnecessary line and airway access that creates additional aerosolization risk. After the transport, follow your service's decontamination protocols for the aircraft or the ambulance and your equipment. Very important to sterilize everything after you have a patient with a respiratory infection. Um, Err on the side of caution all the time. Um, the use of filters is also kind of a point of contention. Typically, we filter vents, on the inspiratory side, and there's an exhalation filter. We put a filter on the inspiratory line, but other modalities um, started to come out with filters as well. So bag valve masks. You can get BVMs that are filtered. Nebulizers. You can filter nebulizers. Now they're not foolproof. They're not perfect, but they're helpful. Um, BiPAP. BiPAP is harder because the filter is at the machine typically and not at the patient interface. But they do make filters that kind of look like your asbestos N95 type your hazmat type mask. And I would encourage you to seek that out. And if you don't carry those on your rig, maybe put a feeler out to your one up and see if you can get some non-rebreathers. We ended up having to order um, filtered non-rebreathers from Canada because it was the only place in the world that manufactured them. They didn't exist before COVID. But one company, I forget the name, but they developed an N95 with built-in filters, and that was a game changer. It really was, because you can't transport somebody in within the hospital on high flow. Um, Most of them don't have battery backups. They would blow through oxygen tanks like crazy. Kind of the same for BiPAPs, being non-invasive with the exhalation port here. So there's air going out into the environment and infecting everything around it. Bag valve masks, same thing. Bag and bagging, where does the air go? It's not an active exhalation filter. It's passive. It just shoots out. If you've ever used an LTV ventilator, man, those things just like they spray everywhere because transport vents typically are single limb circuits So the exhalation is to ambient air. It's not back into the machine where it's recycled. So um, the idea of containing respiratory infections, um, it strangely has evolved more in the last like 5 years than it had in the 20 preceding that. So I mean that's a great thing, but at the same time, folks who have been in the field for a long time and are not used to it, nobody likes change, right? So, oh, well, I'm not going to put that on, or oh, I'm not going to wear that. Well, I mean, things exist for a reason. You should. Whenever you're dealing with a patient who's got a respiratory infection, and any of the ones that we've talked about or others, it's important to pay attention to high risk populations and red flags, and apply your clinical judgment beyond the numbers that you see on the monitor. Um, Extremes of age, so infants, the elderly, pregnant patients, immunocompromised patients, those on chemo, those who've had transplants, those who are HIV positive, anybody with significant cardiopulmonary comorbidities. Um, they 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 typically deteriorate quicker than those who do not fall under those categories. Your they typically have limited respiratory reserve, and can deteriorate a lot faster than their initial presentation suggests. Immunocompromised patients, organ transplant recipients, patients on chronic steroid use or biologics, like we talked about in the pharmacology piece, those folks have a higher risk of developing a more severe pneumonia with organisms, and a pace of deterioration that healthy hosts don't usually see. Um, Pregnant patients carry a specific risk of rapid hypoxemia because of their reduced FRC, functional residual capacity, and their increased metabolic oxygen demand. Uh, Red flags are the indicators that should tell you, okay, this patient is on the edge. A rapidly increasing oxygen requirement over the last 1 to 2 hours, rising work of breathing despite therapy, SpO2 below 90% on high flow oxygen, altered mental status, any hemodynamic instability. When you see any of those red flags, don't wait to see if they resolve because they likely will not. Instead, escalate your intervention immediately. Get on the phone, talk to your provider, tell them what's going on and how you feel the patient is doing and where they're headed. Um, they want the patient to be in as good a shape as possible when they get them. Um, so in transport, I would rather intubate, early in a controlled setting, than to perform an emergency intubation because the patient lost the ability to protect their airway. Especially if you're, going down 94 or 131 at 70 miles an hour. I mean, I mean that. Be smart with your decision making to make it easier on yourself, because the easier it is on yourself, the better it's going to go for your patient. Um, Always clarify the patient's code status, and their goals of care before you depart, if at all possible, especially in patients who are frail, or have multiple comorbidities. So let me close with the core principles from this particular lecture, and thankfully it's a little shorter than the others. The pathogens change. So whether it's bacterial or viral or fungal, the pathogens change, but the failure modes are consistent. What makes them fail? Well, hypoxemia from VQ mismatch and shunt, increased work of breathing, secretion burden, sepsis physiology. Your management should be driven by the actual physiology, not the organism. Lung protective ventilation applies to every intubated infectious respiratory patient. The oxygen escalation ladder, so low flow to high flow to NIV to a vent, that's the same regardless of whether the pathogen is RSV, influenza, gram-negative pneumonia, whatever. The infection prevention protects you and your crew and your ambulance or helicopter or airplane and every patient that you transport after the current one that has the infection. It's a professional obligation, not a personal choice. Um, your highest risk patients, infants, elderly, immunocompromised, pregnant, etc., they deserve your lowest threshold for escalation and your most vigilant monitoring. Know the red flags, act early, and communicate clearly with the receiving team about what you saw and what you did. And in terms of questions to ask yourself, as you're thinking, um, while you're en route, how will you maintain their oxygenation and ventilation? How will you protect their hemodynamics? And how will you prevent cross infection from the patient to you, your partner, and other patients afterward that you pick up? Um, these bugs are gross. They really are, and they are debilitating and often deadly. So do not take them lightly. Do not give in to peer pressure. Like, oh, I know so and so doesn't wear such and such, so I'm not going to either. Don't be that person. Look out for yourself. When you look out for yourself, you're looking out for others as well. It's one of those things where me first um, also means everybody benefits. So go with that. Protect yourself and be smart about it.